Hello and welcome to our broadcast on pregnancy and arthritis. My name is Gráinne O'Leary and I'm Chief Executive in Arthritis Ireland. Every year there are some 60,000 babies born in Ireland, and 1/3 of those are born to first-time mothers. We're here today to talk about pregnancy and arthritis. Many of you may have questions about becoming pregnant or having a baby when you have arthritis. Undoubtedly there are some challenges and some questions that you will have. So here to talk to me today about this is Professor Doug Veale, who is a consultant rheumatologist in St Vincent's University Hospital. You're very welcome, Doug. Thank you for joining us.
Thank you, Gráinne.
Okay, so I'll start off with my first question. When we say that arthritis can affect a pregnancy, we're talking about all forms of arthritis, or are we talking about specific conditions?
Well, primarily it relates to inflammatory arthritis. So that would include what most people would recognize as rheumatoid arthritis, and the second commonest inflammatory arthritis is psoriatic arthritis, but also ankylosing spondylitis and some of the connective tissue diseases. And again, lupus is probably the best known of those. But these are the commonest forms of arthritis that actually would impact on a pregnancy, or indeed the pregnancy might impact on the disease.
Okay, thank you very much. So I suppose a follow-up question there might be, when people are thinking about having a baby, is there a best time for having a baby? Is it a choice between staying in control of your disease and the possibility of parenthood?
No, and that's one of the things that we've really worked towards now over the last maybe 5 years or so in developing our clinics, which focus on young women who really want to actually have a baby. Is actually the planning of the baby. So it shouldn't be a choice. We think it's very possible for the vast majority of young women who do suffer from arthritis to have a successful pregnancy and to have actually an uneventful pregnancy. So the choice really, I think, should be the patients when they want to have the baby. We would advise that ideally they should be in complete control of their disease. So the disease should be actually well maintained on medication before they conceive.
Okay, thank you. And just, you mentioned earlier about inflammatory forms of arthritis. What is it about inflammatory forms of arthritis that make them an issue for people, trying to get pregnant?
Sure. So, briefly, inflammatory arthritis involves activation of the immune system. And as most people know, the immune system is there to protect us from bugs and bacteria and infections. But in autoimmune situations, the immune system actually reacts against the individual. And often that, as in rheumatoid arthritis, which is the sort of prime example, the immune system will produce antibodies that then appear to attack the joints. And when the immune system is active, there's inflammation in the joints, so they become hot and red. And on the inside, that involves the immune cells actually getting into the joint and producing chemicals which actually produce pain and produce inflammation. Now, those same chemicals can actually circulate in the blood, and they're usually proteins which are produced by the immune system, and they can actually cause an environment, I guess, within the mother's body, which is not 100% conducive to either getting pregnant or maintaining a pregnancy. And so that inflammation that's in the body can actually impact on the pregnancy and of course, impact on the growing baby.
Okay, and I suppose a question we often get asked is about the so-called arthritis gene. Many forms of arthritis, they can run in families, as we know, and there's always been a lot of interest in this arthritis gene. But it's natural, I suppose, when somebody might find themselves pregnant, then that they're concerned about passing that gene on to their children. What would you say to them?
Sure. So I think the first thing to say is that there's actually now many genes associated with arthritis. There's not a single gene that is implicated, and some have stronger associations than others. But in fact, there is a family history often in inflammatory arthritis, and indeed there's a family history often in all autoimmune diseases, including diabetes and thyroid disease, which probably are just as common as rheumatoid arthritis. The gene is rarely directly passed from a mother to the child, or indeed from the father to the child. So, with most of these genes, there's maybe a 1 in 2 or 1 in 4 chance of the gene being passed through the germline. But it would be unusual for the gene being passed to be the only factor involved in the arthritis. Usually, there's actually we talk about this first hit, second hit sort of theory that the gene may be one part of why people develop arthritis, but actually they need other things, other triggers that might actually activate that gene to actually cause arthritis. So it's not that common that a mother and a child would suffer from the same form of arthritis or automatically get arthritis in the family. It's often, removed, so maybe in a cousin or an aunt or an uncle that the family history actually comes through.
Is there a greater risk of miscarriage with arthritis?
There's an increased risk of miscarriage if the arthritis is active. And in fact, I guess the general message would be that if the arthritis is active, then there's a higher risk of all sorts of complications, not just miscarriage. So that is why we prefer to try and have the disease very well controlled from the time of conception right through the pregnancy to the delivery, and indeed after the delivery. If the mum wants to breastfeed, we'd like them to be as fit and healthy as they can be, during that time. So we think of the pregnancy as a journey from the planning stage right through the conception, through the pregnancy, and into the first period after the pregnancy, to achieve the best results in terms of a healthy baby, but also a healthy mum.
Okay. And in terms of you mentioned there about disease activity or having active disease, does that affect fertility then in that case? And is there a link between that disease activity and how long it might take somebody to get pregnant? And for instance, as well, linked to that, what if somebody's actually in remission? What are the factors at play there?
So, as I mentioned earlier, the problem with active disease is that there's inflammation in the mother's body. And we believe that, and some of the data now does show that there is a lower fertility if the disease is active. And while we can't measure that directly, what we can do is measure it indirectly so that we know that in the populations of young women who are trying to achieve a pregnancy, there's a higher rate of infertility associated with active disease than there is with those who are in remission. Now, that is a temporary thing, and it may, we believe that it is dependent on the inflammation. So if we get the inflammation under control, then there's no reason why the fertility can actually return to normal.
A common topic in relation to pregnancy is things like taking supplements. Are there particular supplements that a person with arthritis might take at this time? Obviously we hear a lot about folic acid, but also what about things like iron, vitamin D?
Yeah, so supplements are important to all expectant mums, and indeed the advice that we give in our clinic is that if actually from the time that they are actually planning their pregnancy and looking to conceive, that they would actually take folic acid on a daily basis. And that's not particularly for the arthritis, but folic acid it does prevent problems arising from the development of the nervous system in the baby. And so we've known that for many years now, that folic acid supplementation is very important. Now, patients with arthritis do take folic acid supplements sometimes when they're on specific treatments. But the dose that is actually required preconception and during the early stages of pregnancy is much higher than our patients would normally be used to. There are certain medications which we think are absolutely contraindicated when a mum is trying to get pregnant. And the most important one of those is called methotrexate. And that's the one that we usually supplement with folic acid. So yes, continue the folic acid supplementation, increase the dosage, but absolutely make sure that the methotrexate is stopped at least 3 months before you're planning to conceive. Sorry, you mentioned the other supplements that I should mention. That iron is often given, if the mum is in any way deficient in iron, and iron supplementation is actually very commonly given. But other than that, there's no specific supplementation that should be given to patients with arthritis who are embarking on a pregnancy.
And we started to talk there a little bit about medications, and I mean, obviously most people with inflammatory arthritis will be on a medication, regime, some of which might be, biologic medications or disease-modifying agents. Just can you tell us a little bit more about the drugs? You mentioned methotrexate there, but are there other drugs that people should be stopping before getting pregnant?
Sure. So one of the main reasons why rheumatologists actually started to work more closely with the maternity hospitals was because of the lack of information and the lack of knowledge, not only that mums had or dads had who were about to embark on a pregnancy, but actually a lack of knowledge shared between specialists about what drugs were safe and what drugs weren't safe. Now, we've known for some time that certain medications that have been around for a long time are actually relatively safe right through pregnancy. So that, and particularly for arthritis medications, that includes hydroxychloroquine, which is sometimes known as Plaquenil, Imuran, which is the generic name for Imuran is azathioprine, and also steroids. And all of these drugs have been around and used in the treatment of arthritis for perhaps the last 60, 70 years. And we know from the study of these medications that actually many of them are not transferred to the baby when the baby's in the uterus, in the womb. And so they're regarded as very safe during pregnancy. And so with the evidence that we have built up over the last 70 years, we're in a position to have that discussion with a mum. Now, some mums still don't want to take medication, and that's their choice, obviously. But we can at least give them the evidence, and then they're in a position to actually ask the relevant questions and make up their own mind. Now, in the last 20 years, of course, there's been an explosion of medications, primarily the biologic drugs, and these drugs are based. The drug itself is not a chemical, but it's a biologic. It's an antibody, and as I mentioned earlier, the immune system makes antibodies to actually protect us from infections. And that's a good thing. The antibodies that are generated for treatments actually are very specific medications. So they usually bind a particular molecule in the immune system, and then they block the inflammation that is produced by that molecule. So they are very specific to their target. They act on a single molecule, and they have an effect that is a good effect by reducing the inflammation. And because they're so specific, they have very few what we call off-target effects. So they don't affect other molecules or other cells in the body. And again, because they're very large molecules, they're large, usually proteins, they don't often transfer readily to the baby. Now, we've shown that in some studies have shown that actually there's a very small amount of the antibody transfers across the placenta to the baby during pregnancy. But certainly the data that has been gathered over the last 20 years would suggest that in most cases, there doesn't appear to be any risk of these monoclonal antibodies, these new biologic treatments, to the baby during the pregnancy.
Okay, and that brings us to another important issue. What happens if it's the man who has arthritis and is taking medication? How does their arthritis or their medication affect their chances of becoming a dad? And do different medications affect a man's fertility differently? Yes,
so there's one particular medication that we don't use that often now, but certainly was developed in the sort of 1960s, 70s, and that is a drug called silazapyrin or sulfasalazine. And the structure of sulfasalazine is based on an aspirin molecule, actually, but at the same time, in males, a small number of men taking sulfasalazine have been noted to have a reduced sperm count, and that may certainly adversely affect their fertility. Now, again, it is a temporary phenomenon, so if the drug is stopped, then the sperm count does appear to rise in almost all of the cases, and those males do become fertile again. In terms of the other medications, there doesn't appear to be any direct effect on fertility. And in terms of the ability then of a man to father a baby, there doesn't appear to be any risk associated with all the other medications that we use. The one I would also say there's been some confusion, and certainly recently there's been a change in the advice, is again with regard to methotrexate. It was the dogma really to give the advice that methotrexate should be stopped in males who are trying to conceive up until about earlier this year, when data really came through to show that there was very little evidence to suggest that there was an adverse impact on the males. So that seems to be a different effect for methotrexate, that it definitely should be stopped in females considering conception, but it doesn't necessarily have to be stopped in males who are considering conception. Now, I should just add the caveat that if you look at the guidelines on the various websites, that the advice is still to stop the methotrexate for the males, but we're suggesting that advice is changed in light of the new evidence that has come online.
So if patients want to get more information, obviously we can't go into every single medication that people might be on here, but if people want to learn more about their medications and what is suitable when they're thinking about getting pregnant, what would you suggest they do, or where would you suggest they go to get that information?
Well, I think I'd recommend them go to the Arthritis Ireland website initially, because I think that a lot of the information on the Arthritis Ireland website is actually phrased in a very understandable language. I think after that, I think they should talk to their specialist, and certainly they could also discuss that with their specialist obstetrician or their gynecologist if they're in that planning phase. And I would advise people to actually get that information before they actually consider having, before they consider actually embarking on a pregnancy, rather than waiting until they are pregnant and then trying to find out.
Yeah, so start early, have that conversation, do the research, gather the information.
Yeah, and actually our advice now, because one of the reasons that makes this issue so important, of course, is that inflammatory forms of arthritis do affect women more than they affect men. And they also affect women in this phase of their lives when they are planning a family. So it's young women in their 20s, 30s and 40s that actually have a higher instance of inflammatory arthritis. So it tends to impact on this group of the society at a time when they are most wanting to actually have a pregnancy. So we would suggest that from the initial diagnosis, that this discussion is part of the overall discussion about the disease and about the treatment and the impacts of the disease and the treatment on their lives.
Just moving on now to, obviously during pregnancy, many women experience, aches, pains, fatigue. It's a fairly normal part of being pregnant. But how does arthritis, affect pregnancy? Can blood tests distinguish whether it's the pregnancy or the arthritis that's causing the symptoms? Can you tell us a little bit more about that?
Yeah, actually, during the pregnancy, the blood tests aren't as useful as they would be in a non-pregnant situation, if you like. And the blood tests that we use in the routine clinics sometimes are not as useful to detect inflammation, and that's because some of these blood tests do become abnormal due to the pregnancy as well. Although that is often there may be a different degree to which the blood test is abnormal due to pregnancy and due to the disease. So we rely more on the symptoms that the patient actually describes, and also on the signs that we can pick up looking and examining the patient. So certainly symptoms such as fatigue, as you say, are common during pregnancy. And so if it was an increase in fatigue, we'd like to look a little bit more closely into that and maybe think about symptoms and ask about symptoms such as joint swelling and joint tenderness, and also stiffness. If the early morning stiffness that is relieved by exercise is a common symptom associated with inflammatory arthritis. And so we would ask about that during the pregnancy to see if that has changed. And so they're the main symptoms that we would focus on: the morning stiffness, the joint swelling, and the joint tenderness. And if they increase during the pregnancy, then we would say it's more likely that that's due to the arthritis than due to pregnancy. The aches and pains associated with pregnancy would be often more associated with specific areas in the body. So the lower back is one of the main areas where actually pain and stiffness often increases during pregnancy. And that's due to the ligaments often becoming a little bit looser. The ligaments actually become a little bit more flexible, and that's obviously to allow the baby to be delivered, so that when the baby's being delivered, the pelvis expands to allow the baby out. And so that can be associated with some pain and some symptoms, some aching. And of course, the actual weight of the baby as the pregnancy proceeds can actually put a greater strain on the lower back. And the other areas that pregnant mums often find symptoms is in the hands, but not usually in the joints of the fingers, but actually from compression of the carpal tunnel nerve, or the median nerve in the carpal tunnel. And what we call carpal tunnel syndrome is a common symptom that increases due to increased fluid retention secondary to the pregnancy. And the symptoms there are increased in tingling or pins and needles in the fingers, often early in the morning time when the pressure is higher around the nerve. And that's just a compression of the nerve. It's a very simple mechanical problem actually that's associated with the pregnancy, but it can be very distressing because it can also cause some reduction in strength, which is temporary.
So it does dissipate after the pregnancy?
It does dissipate after the pregnancy, yeah, and almost invariably returns to normal, but occasionally will benefit from a steroid injection during the pregnancy around the nerve to release some of that pressure.
So I guess when women become pregnant, and they start gathering information, one of the things they often read about is remission during pregnancy, and I'm sure that's a question you often get asked by your patients. How common is it to go into remission during pregnancy?
Yeah, so as I say, now we try and time the pregnancy so that the mum is in remission before they conceive. But certainly there is this phenomenon which has been described, I guess, over the last 60, 70 years, that if the arthritis is active and the mum conceives, that the arthritis may actually go into remission. And that's a phenomenon that we certainly associate more with rheumatoid arthritis, although we have just actually looked at and have evidence now that it also occurs in psoriatic arthritis, which is the second commonest inflammatory arthritis that we see. So it is a phenomenon, and it is real, and it probably would occur in about 50% of cases where the arthritis is active, pregnancy is achieved, and the mum will actually see a slow but progressive reduction in the pain and the swelling and the inflammation associated with the arthritis. And all of the measures of arthritis that we see can be actually seen to reduce as the pregnancy progresses. And that's great news if it does occur. If it doesn't occur, then we would still advise that we look at some of the treatments, some of the medications that we know are safe, as I mentioned earlier on. And we would be less, I think, hesitant now to advise a mum who gets a flare in their arthritis or whose arthritis is very active to start on treatment. And the most important reasoning for that is that we believe if the mum is healthy throughout the pregnancy, then there's a better chance of the baby being healthy throughout the pregnancy. And so we often tell mums that, there's a higher chance of having a healthy baby if you're healthy and if your disease is in remission throughout the pregnancy. And that's really what we're trying to achieve in most of the maternity clinics now, that we are actually, working side by side with the obstetrician and the midwife and the arthritis specialist nurse to achieve this steady state, if you like, of remission throughout the pregnancy, before and throughout the journey.
You mentioned rheumatoid and psoriatic arthritis there in terms of remission. What about ankylosing spondylitis? Yeah, so
ankylosing spondylitis, certainly we don't have as much data on it in terms of going into remission, but I don't have any reason to believe that it would act any differently from rheumatoid or psoriatic arthritis. It would be most in terms of the symptoms, would be most associated with psoriatic arthritis, as they fall into the same sort of broad classification category. So I think that they probably behave in the same way, actually. And the data that we published just last year, actually, in the European journal, the Annals of Rheumatic Disease, showed that mums with psoriatic arthritis do go into remission during pregnancy, but they do have a higher rate of relapse or flare after the baby is born, usually around sort of 6 to 8 weeks after the baby is born. So we now advise those mums to pay particular attention to their symptoms around that time. And we schedule them now routinely for a review appointment in the rheumatology clinic at 6 to 8 weeks after the baby's born.
Okay. Moving on to a different form of rheumatic disease. There might be people watching who have lupus, and we know that there is a higher risk of complications with this disease. But healthcare developments have meant that lupus patients have had successful pregnancies during quieter periods of their disease. What would you say to somebody with lupus who is planning a pregnancy?
So I think lupus, it's more of a systemic disease, that it can affect lots of different organs within the body. I think it's even more important for that reason that the mum's lupus is in remission before they conceive. And that's really, it's even more critical, if you like, for patients with lupus than it is for patients with inflammatory arthritis. So, and that's particularly important, I think, because of potential effect of lupus on the kidney, because also, as most people would know, that high blood pressure is a particular risk to the baby during pregnancy. And of course, high blood pressure can impact on the kidney as well. And so the absolutely critical thing for lupus patients is that their disease in remission when they conceive, and that their blood pressure is well controlled throughout the pregnancy to prevent any possible complications affecting the kidney. Thankfully, lupus isn't as common as rheumatoid arthritis or psoriatic arthritis, but we do see lots of mums who have other forms of connective tissue disease which are a little bit milder than lupus. And the one that I would single out for mention is Sjogren's syndrome. So Sjogren's syndrome is usually a mild form of connective tissue disease, but it's associated with a specific antibody. And we need to know whether that antibody is present before a pregnancy or during a pregnancy, because of course that is one example where the antibody does cross over the placenta and can cause a specific complication in the baby, where it attacks the nerves in the heart, and that can cause a block, what's called heart block. So it blocks the conduction of the electrical impulse, which makes the heart beat. And if we know about it in advance, then we can monitor it very closely, number one. And number two, when the baby's born, we can detect if there is any heart block present and identify very quickly whether that baby needs a pacemaker or not. So that's a very specific instance. It's not very common, but it's a very specific instance where there is an inflammatory disease associated with an antibody that can actually directly cause a problem in the baby at birth. But if we can know about it in advance, then we can prevent any issues arising from that complication.
Okay. Moving on now to topic of physical activity, exercise. So we know that it's really important for people with arthritis in general. Does this change during pregnancy? And are there particular types of exercise that are particularly beneficial or suitable for people when they're pregnant?
No is the simple answer. Exercise is always good. I think, our general advice would be if a joint is actively inflamed, if it's swollen or painful, that you would avoid exercising it too much. So the classic example would be, if you've got a sore knee or a swollen knee, then you don't go jogging. In that case, we would recommend certainly exercise in the pool, first of all. That's exercise in the swimming pool, where the pool takes the body weight out of the equation, if you like, is definitely beneficial. And we see that with hydrotherapy, for instance, which has long been used for the treatment of arthritis. And then after the pool, non-weight bearing exercise. So if you've a sore knee, again, get on an exercise bike, where, again, you take the body weight out of the equation and you can exercise as long as it's not causing pain. That's the critical message, is if you can exercise without making your pain worse or causing the inflammation to be worse in the joint, then by all means do it. In the early stages of pregnancy, if you're a fit young mum, there's no reasons why you can't continue doing whatever exercise you are used to doing. And I certainly wouldn't advise changing exercise. Later on in the pregnancy, of course, it becomes more difficult anyway because of the bump, and the bump often gets in the way of some other forms of exercise. But I think by and large, the advice would be swimming is good, exercising in the pool is good, and non-weight bearing exercises are very good. But I think it's important that mums do keep up their fitness throughout the pregnancy and after also. Yeah.
And speaking of after the pregnancy, we know that many women do experience that postpartum flare that you mentioned earlier. Is there anything that can be done to prevent that flare happening at that 6 to 8 week period that you spoke about earlier?
Well, I think that certainly as the medications have become as we've got better information about the safety of the medications. Certainly we are continuing most of those medications now, in most cases throughout the pregnancy, and that's throughout the post-pregnancy period also. So again, we think it's really important to maintain that state of remission throughout the pregnancy and beyond. So I think that we're seeing less of the flares in the mums who elect to stay on the medication. And that would be, I think, the most important message. In those mums who are not comfortable with continuing medication and have stopped it, then we can't predict exactly when it's going to occur, but at least we can actually preempt the flare by actually seeing them at an earlier stage. And that's why we try and schedule an appointment around the 6 to 8 week mark, when we think it's that the beginning of that flare possibility is most likely. And try and actually re-establish any medication that they were on at an earlier stage. Now, again, we know that many of these medications are actually safe during breastfeeding. And so as we become more comfortable with getting medication started during the breastfeeding period, again, I think we will hopefully prevent a lot of those flare episodes from occurring.
Is there a relationship between how a person's arthritis is during pregnancy and that postpartum potential flare?
Not specifically, no. I mean, as I said, many the mums will go into remission during pregnancy, and we can't yet define which ones will flare and which mums won't flare after the pregnancy. But we are looking at that in a study ongoing now, actually, in the National Maternity Hospital with Professor McAuliffe. We're looking at markers of the immune system throughout the pregnancy to see, can we actually identify markers which will predict those mums who might flare during the pregnancy and those mums who actually will flare after the pregnancy. So we hope to have an answer to that question in time.
Yeah, no, that's great to see that research happening. You mentioned there about breastfeeding as well in the postpartum phase, and according to the World Health Organization, we know that babies are recommended to be exclusively breastfed for the first 6 months of their life, and we know breast milk has huge beneficial effects for infants. What advice would you give to new mums with arthritis who are considering breastfeeding? And also, I know a key question there would be, can the drugs be passed on in the breast milk?
So unfortunately, actually, one of the studies we did showed that the rate of breastfeeding in Ireland is actually particularly low compared to other European countries, which I think is disappointing. Although I think it might be changing. I think young mums are more inclined now to breastfeed. And that it's a multifactorial problem. I think, it depends on, many different factors, like, are they going back to work? Have they got help in the house? And, lots of different factors, I think, are important in terms of breastfeeding. Our advice is that, if mums really want to breastfeed, that there shouldn't be any reason why they don't. We know that most of the medications that the mums take for, we know which medications do cross over in the breast milk, and which may, be a slight risk factor. There's no major risk factors, I think, but many of the medications now are safe, and we know that many of the newer medications, particularly the biologic drugs, are actually only present in breast milk in a very low concentration. And we also think, because those medications are proteins, that when they're ingested by the baby's digestive system actually breaks them down as they would with a food particle. So they don't actually get into the baby's system and cause a particular risk. So we think that most of the biologic treatments are safe during breastfeeding. I think the ones that we are concerned about are the medications which are, if you like, the old-fashioned chemical.
So like methotrexate.
Yeah, like methotrexate and the non-steroidal anti-inflammatory drugs, because we know that they can be passed over in breast milk and that they may have an impact on the baby as well, because they may be absorbed through the baby's stomach. And so a certain level of those drugs may get into the baby, and that's maybe not ideal, particularly in the first few weeks of life. So I think we have some idea, and we can advise more clearly now about which medications are safest and which ones, may pose certain problems. So I think we can advise on that. But I think by and large, if the mum is in remission, obviously there's very little reason why they shouldn't breastfeed. And in fact, one patient that comes to mind that we were particularly worried about was a young girl who had arthritis from a very young age. So she had juvenile rheumatoid arthritis and had significant disease affecting her hands. And we were worried that actually she may have, specific problems from a purely physical point of view of actually holding the baby, feeding the baby, and that percent. And so we were able to actually get an assessment done before the baby was born with our occupational therapists and our physiotherapists. And so we went through an assessment during the pregnancy and actually discovered that this mum had really no problems actually holding the baby or actually changing nappies, doing all the things that the mum needed to do when the baby was born. And so we were able to reassure them at a very early stage, before the baby was born, that actually they were very capable with the physical side of actually having a baby and holding the baby and all the things associated with breastfeeding and changing.
So that might be an important thing for people as well who have, particular problems, maybe particular joints that, when they have a baby and they maybe plan to breastfeed, for instance, that they,
Absolutely.
Again, speak to their healthcare team within the clinic about that and maybe plan and...
Absolutely, we would advise that for those young mums who've been affected by arthritis at an early age, I think one message is that they can have a baby, because often they were coming in and asking us, could they actually get pregnant? Would the pregnancy be successful, and would they be able to cope with the baby after delivery? So the message, I think, is very much yes. In most cases, I think they can. But if they're worried about this, get an MDT, a multidisciplinary team assessment. Get the physiotherapist and the occupational therapist involved at an early stage and reassure them through the assessment process that they will be able to cope with the baby when the baby comes along.
So we've talked about lots of issues there. We've had lots of questions and the information has been just fantastic. Just a last question for you. What would be your key piece of advice that you'd give to somebody with arthritis when it comes to pregnancy or starting a family? So whether it's male or female. Yeah,
so I think our key advice is to plan the process. Pregnancy is a journey. And there's very few reasons now, I think, with our experience, that mums or dads should not consider having a family because they suffer from arthritis. As long as they plan the experience from the earliest stage, make sure that their disease is as well controlled as it can be before they conceive, and that they get the right assessments, see the right specialists, and ask the right questions through the process.
Okay, thank you so much, Doug. We've covered a huge amount of information over that time, so I think people will find that really reassuring that are watching at home.
Thank you.
Thank you so much for joining us for this broadcast on pregnancy and arthritis. Do remember that we have a range of resources and information on our website, arthritisireland.ie. We also have some specific online groups via Facebook that you might like to join. They are on the topics of pregnancy and parenting. And you can also contact our helpline for information and support on 0818 252 846. Once again, thank you very much for watching, and we hope to see you again soon.